Attendees are in listen-only mode.
Hello, thank you for your patience. Welcome to the Admissions Avoidance and Early Supported Discharge webinar presented by John Stephenson, Associate Medical Director from East Midlands Ambulance Service. First of all, we have a few simple housekeeping points for this ECIP webinar. This session is being recorded and the recording will be available to view on our website shortly. All attendees are muted to avoid background noise during the recording. At the end of the presentation, there will be the opportunity to answer questions. If you have a question, please use the raise your hand option in the panel on the right-hand side of your screen. Alternatively, you can write your question in the questions section on the panel. During the question and answer section, we will unmute you to ask your question in person. Thank you, and I'll now hand you over to John for the webinar. Thank you, John.
Thank you. Good afternoon, everybody. I'm afraid I'm going to find this very strange because I'm used to having an audience that at least gives some feedback as whether they want to throw tomatoes or whether they're enjoying it. So I apologise in advance. I just thought I'd just start briefly with a very short introduction as to who I am and why I'm here. I am currently the Associate Medical Director at East Midlands Ambulance Service, but I previously was a GP, PCT Medical Director, and also have run as an Ops Director community hospital beds as well. So I've been involved in a lot of this work for many years, so I tend to dip in and out of different areas. So I hope that helps you understand why I've got this sort of before and after session, I think is the best way to describe it. So what do I want to talk about today? I want to talk about admission avoidance. So basically, if we're looking at a whole system approach, the question is to make the answer is to make the system work better, is to only let the people into the system who really need to be there, and also at the other end to maintain the flow, to have a system that allows people to come out nice and quickly, so that there's like a seamless service from the patient's home at the start to the patient hopefully coming home at the end of it. So from an admission avoidance perspective, I'm going to start talking about primary care, out-of-hours services, keeping people in care homes where possible, looking at how we struggle to some extent with the workforce available to us, and so maximising our pharmacy potential. And then one of the major causes that impacts my current day-to-day working is falls, and how that impacts on the ambulance service and then on the acute sector. It's a bit on falls prevention. And then we're going to do the sort of the second part of the talk, talking about how we get people home quickly. So I'm not an expert on social care, but I will briefly talk about how the primary care side of supporting people home and getting them assessed is the best way to make it all work. So I hope that makes sense for you, and I hope that's what you're expecting, because otherwise you're in for an unusual afternoon. So the first thing is, when you're a patient, looking from their perspective, it's how do they get into the system and how do they make it work. So when we look at patient choice, we have to look at how we get the patients to the right place so that they get the care that they need and they don't end up traveling to places that they don't need to travel to. So just looking from the simple, cartoon pictures on the screen, we'll often have restrictions on services. So you want to go to primary care, but you can't get an appointment. It's equivalent to the door being too small and you can't get through. So in an ideal world, we shrink the person or enlarge the door. It's easy in a cartoon. But when you're looking at a restricted workforce, an overstretched workforce, and an increasing level of demand, it's how do we manage that by encouraging people to be able to make the right choice to get the right care, because that's the way that we can encourage the system to work best. So from a primary care perspective, it's getting patients to have easily accessible services, designing in that availability so that the people who need an appointment and want an appointment will actually, with a primary care problem, will end up seeing somebody who is an expertise in primary care, and not saying, well, I can't get an appointment for several days, so I'm going to turn up at the emergency department. So I'm old now, and when I was a lad and I worked in the casualty department in Leeds, it would be not uncommon for minors to wait sometimes 6, sometimes even 12 hours to see someone. So it wasn't a good service, but it also wasn't a good choice for the patients. You only came if you really needed to. Whereas now, in order to manage our 4-hour targets and our 4-hour standards, one of the best things to do is to turn around the walk-in patients who are quick and easy very quickly, which means it's often quicker to go to an emergency department, see someone who's not an expert in primary care, not necessarily get your problem solved, than go to your GP. So what we need to look at is how can we design our services to make them accessible. So you can look at your primary care and how you manage your appointments, how you manage walk-ins, how you manage same-day attenders. And there are many, many, many ways of doing this, but it's trying to make it accessible to deal with what your patients feel they need to access. One of the things that works in some places is to put primary care into the emergency department, so actually you have a GP working in there so that anyone who walks in, who, when asked the question, have you presented with a problem that you would normally go to your GP with, can be diverted away from the emergency department staff and straight into general practice. This works really well, but you have to have enough demand in the department to make it worthwhile having a GP. Other places manage it by having GP surgeries that are willing to offer immediate appointments, so that if you turn up at ED with a general practice type problem, they're able to offer them an appointment with their GP there and then to go back to general practice. So what I'm saying is we need to design in some availability and to look at where we have built-in blocks to stop people accessing services in hours, and whether that's because we've built the services around what suits us as the doctors or us as the staff, and actually try and find ways to make it easier for people to access general practice. So some people are comfortable with telephone conversations and consultations. Some people are happy with web-based email consultations, and all of that, the variability is down to how you as a clinician and your patients feel comfortable that they're getting safe access and a safe service. So we need to look at the system and try and make it work. So one of the issues that came around with the change in the GP contract a few years ago was when GPs stopped working weekends. And certainly when I was a GP, being able to see someone on a Friday and want to review them on a Saturday morning was a useful tool. From an ambulance perspective, by removing the Saturday morning surgeries, we increased ambulance calls over the weekend by nearly 20%. So the patients were looking for somewhere else to access care. So one thing to look at is, whether within a primary care service, maybe in each practice, maybe in each locality, is there a facility to run a normal type GP surgeries over particularly blank holiday weekends, and provide the service that actually deals with the patient's problems without them ending up in the emergency department being seen by a junior doctor who's not used with those sort of presentations, who will then investigate and admit what a GP would use the great healer of time for and review a few days later. So look at the responsiveness of your surgeries, look at the demands that the patients put upon it, and try and match those, because if people are getting the service that they want that meets their needs, they're unlikely to go beyond and look for other alternatives. But generally what we have generated over the last few years is a group of patients who want instant access now, and so because of that we have to look at our service and say, well, how can we meet some of that demand that has built up? Another problem that we have is, what is primary care? Do the public understand what we are trying to sell? The Ronseal test, does it do what it says on the tin? So in the old days you had a primary care and you had a hospital, and there was very little in between. And then we've developed walk-in centres, we've developed out-of-hours centres, we've developed drop-in centres, we've got minor injury units that deal with minor ailments, and so we also have a group of patients who might be a bit confused And I think the other thing is that it's not just the patients that are confused. You're talking from an ambulance perspective. Do the ambulance staff in your area know what each of those services are able to deal with? So there's something about your directory of service explaining to the people around you what we can do to make the whole service understandable for the patients and for our other clinical colleagues. And it may be that over time we need to look at some unification of the descriptions of places so that people know what they're going to get in each place, which would help them turn up and know what sort of service that can meet their needs. When we look at unplanned admissions and urgent care, there are a few areas where there is very good evidence that some interventions can actually decrease admissions safely, better quality of care, keeping people at home in their own environment. Just a small selection here that I've chosen in the Safer, Faster, Better booklet. The important ones to me is, if we get people to self-manage their own asthma and their own COPD, they stay out of hospital. I think also an understanding of your disease, having options to increase your treatment when necessary, having standby antibiotics and steroids under a carefully defined program gives good care and actually probably decreases the risk of people going into hospital and getting unnecessary infections. So self-management is effective, works well, but does need some investment in time to actually ensure that people understand the management that they're going to look after themselves. And to be honest, at the end of the day, you can end up with some very good expert patients who can look after themselves very well. Pulmonary rehabilitation, following an exacerbation of COPD, it's been shown quite clearly that a bit of pulmonary rehabilitation, some exercise, some build-up of your respiratory reserve actually decreases the number of exacerbations requiring hospitalization. So again, something worth investing in, improved quality of life, spend more time out of hospital, good for your patients. Cardiac rehabilitation following admission with coronary heart disease, so post-MI, post-cardiac syndrome, patients who are rehabilitated with gentle supported exercise actually get an improved exercise tolerance and therefore have a better life, but also are less likely to be admitted with problems when they haven't quite understood their disease. But importantly, it's been shown that this doesn't work so well for people who've got asthma or for older patients, probably because the exercise tolerance doesn't build up so much. So if you have limited resources, maybe worth just looking at who you target. Something that doesn't happen so much from a general practice perspective is chronic visiting. And I think this was something that was quite satisfying in the old days, but was quite time consuming and did not appear on an individual basis to have a great deal of admission avoidance value. Luckily, as upon a population basis, it has been shown that if you have regular visiting of at-risk populations, you can put in anticipatory care, but also some of it is down to the self-management and the expectations of the population and their families. If they feel that they're being monitored, observed, and are being prepared for the what-ifs, what to do if this happens, what to do if that happens, can actually mean that people can often defer calling at weekends, for example, because they know they'll get sorted on a Monday by their own team. So looking at some of visiting of at-risk populations, either by community nursing staff or occasionally by the general practitioners, can actually have a good positive effect in terms of quality of care and patient expectations. Frail older people are increasing in number, and again, when there's any signs of a deterioration, having them assessed soon in that deterioration by appropriately qualified decision makers, be that therapists or doctors, with the responsive intermediate care services to step in and provide that extra support or that alteration, can really make a difference to keep frail people at home. And I think all of us by now have had drummed into us the statistic about going into hospital beyond the age of 75 is not a good thing for your long-term life expectancy. So keeping people at home in their own environment is really something very good and something we should be encouraging. So in terms of long-term condition management, the proactive management of long-term conditions with programs that increase knowledge, skill and confidence allows people to manage their physical and mental health. This needs to be supported, they need to have access to someone to ask questions, but as a result of this, they will be better prepared for any deterioration or any crisis that develops and are less likely to seek urgent help, often from people who do not know much about their personal status. So ambulance staff being called out to people with COPD will see someone who's breathless, will take them to the emergency department where they are seen by staff who will see someone who is breathless and will admit them for all sorts of treatment that actually they were probably very much similar to their baseline status before they were taken into hospital. So, plans that show people when deterioration and what their baseline status is can be very helpful for other clinicians. What we do find is that people with long-term conditions who do present acutely often do that because they haven't had this education, there has been inadequate planning and support, and they lack confidence of what to do when there is a problem. So putting these plans in place does provide better care, provides confidence to the patient in the care they're receiving, and helps them understand that they are more in control of their problems. So from a primary care perspective, we know that early diagnosis and treatment reduces the harm and distress to patients, and that by providing effective and timely responses to both adults and children, we can often intervene and provide care that can keep them at home and can stop them thinking that if you're unwell, go to the emergency department, where you may not necessarily see people with the same expertise in the primary care problems. You definitely see people who are experienced in looking after major life-threatening emergencies, but often these patients don't have a major life-threatening emergency but ended up being treated as such. So in primary care, there are a few principles that have been shown to work. Not everyone will suit every practice, but it's a question of looking at what you do and how you work in your practice to make that care better for the patients. So again, from the Safer, Faster, Better program, there's a few suggestions that have been shown to work, and I think it's worth looking at them in your own practice and seeing what could help. So, if you get a small number of requests for urgent home visits, it's a question of, well, actually, they probably need an urgent home visit. So, the days of someone phoning at 8:30 in the morning saying they're acutely short of breath, it going down in the visit book and the doctor turning up at 2, 3, 4 o'clock in the afternoon prior to the next surgery, is probably not a great way to manage that urgent problem. Because, first of all, if they're really sick, they probably would have been better in hospital earlier on. But secondly, if you're going to do some intervention and actually manage to keep them at home, it's probably a lot easier to organise earlier in the day when you can get other clinicians in there early, and you can find a way to keep them in their own home. So a way to try and make this work and decrease the variation you get from different clinicians with the practice is to looking at setting a standard for how you manage these first calls and arranging the first initial assessment, and then you can assess how, as a practice, how well you are addressing these requests for urgent need. So having a duty doctor who's able to be interrupted or actually has a free time in the morning to do these visits when they come up, looking at the time from the call received by the receptionist and how quickly we make that telephone call to check whether actually they may not need a visit, they may actually need an ambulance, for example. So standards help you look at how you're managing these patients and actually will no doubt improve what the patients see in terms of their performance of the practice to their need. There are also questions about how we manage our same-day access. So, it was very common in the past that people would have a a turn up and sit up and wait surgery, but actually a lot of people who want same-day access, same-day care, just need a telephone call or just need a very quick bit of advice about sometimes they might need an occasional prescription, sometimes they need advice on their medication. So a lot of these can be dealt with by telephone or email, and patients are generally quite comfortable with this, but you need to build in time to do this into the practice. So whether it's through the nursing team or through a duty doctor service, someone needs to have the capacity to do this, because you can't fit it in on top of 2 4-hour surgeries. It is not physically possible. Other problems that we've found is that parents who have children who are ill during the night, in the past, who haven't had faith that they could get to see the doctor first thing in the morning and thought they'd ring up at 8 o'clock and be offered an appointment at 5 o'clock that night, would just take the child to the emergency department because they were concerned. The family systems that used to provide that backup and reassurance are often lacking because people live much further away than their parents and grandparents. So having systems whereby people can get in and know they can get in early in the morning with a child who's been ill overnight can remove a lot of that anxiety and encourage people to attend the surgery and get their problem assessed quickly, decrease their anxiety, and hopefully avoid an unnecessary hospital attendance. So basically, a review of how the practice operates, looking at how they would cope with different sorts of presentations, particularly children, particularly the elderly, particularly around those with long-term conditions or continuing care. Look at how the practice copes with those, and just look at, there might be some inefficiencies where you could actually cut out the middleman and get the patient seen quickly and save them the anxiety, save you the later turn up of problems, and actually overall improve the efficiency of your practice. Now, out of hours is a different beast. It's covering large areas, usually with relatively small numbers of staff. But what do the public want from it? They want a quick assessment, they want appropriate signposting, and they want timely face-to-face assessment if required. Now, interestingly, what the police have found, and also what the ambulance services have found, is that the public are relatively good at deciding what needs a 999 service or a 111 service. Similarly with the police, the 999 compared to the 101 service. So the public, as a rule, aren't bad. There's obviously a few exceptions that cause us entertainment, but in general, the public choose the right option. So therefore, when you ring the out-of-hours service through 111, a referral to 999 should be uncommon, because the patients have already looked at themselves and said, you know what, I don't think I've got a life-threatening condition. I often want a bit of advice, I might need a bit of assessment, I might need a bit of minor treatment, but as a rule, the patients are pretty good at deciding what they need. Currently, 111 puts about 6% of calls through to 999 directly, and I think there is some thought that this is probably still a bit too high, but it's still a relatively new learning curve, and obviously algorithms are constantly being updated. So the out-of-hours service needs to be responsive. And how can we help? Well, if you ring 111 and the outcome is that they think you need an appointment with your GP, if you're able to give the patients an appointment there and then for their own surgery in the next couple of days in a time appropriate to their condition, people will be very happy. So allowing the call handlers to directly an appointment makes people feel they've been assessed and been appropriately signposted. However, telling people to then ring back to the surgery when it's open to make an appointment doesn't give them the same cosy feeling. So where possible, this is something that we should be looking at. And we need to minimize hands-off. People don't like ringing a call handler to then be put in touch with one clinician who says they need to speak to another clinician. So And we all know that every time someone has a handoff, there's another assessment that's done. So what we need to try and do is to get to the right person early on. So, and the ideal thing is not to offer people a ring back, it's to be able to do what's called a warm transfer, where you ring 111, you're dealt with by the call handler who says, I think you need to speak to X, and they're able to put you straight through to them. So if you can remove those cues and allow an immediate assessment, it doesn't allow people to start to fret and worry. It allows their problems to be sorted out as soon as possible. So looking at how these systems are handled and how the calls are dealt with really does make a difference. And when it does come to visiting, people will choose the easy option. So if they know that the out-of-hours service is going to take many hours to turn out to visit, they will often just present to the emergency department because it's often easier. So it's always worthwhile having some discussions about expectations and explaining why the patient can wait that length of time, and then they'll understand better the service that they're going to be getting, and if they understand what's happening, they're less likely to be unhappy with it. Another area where we get a lot of concern from is care home management. And I think the first thing I want to say is that when people are in a care home, they are in their home. That is where they live. And so we need to look at, just like we talk about people when they're living in their old homes, it's what we can do to keep them at home. And often that means looking at their care needs, planning their care needs, including regular medication reviews and falls assessments, and get an understanding of what can be cared for within the home, and also potentially how any future health crises can be managed. So the places that do this well have GPs and community staff who visit the care homes on a regular basis, have an understanding of the patients who are in there. And often you'll find that if these situations are well planned and working well, patients who become a bit unwell will be kept until the doctor or the nurse visits, rather than calling for an acute assessment, because the care homes have an understanding of how busy they are, but they also have an understanding that someone's coming, and so some of the concerns are removed from the staff as to what's happening to that patient. I personally think that advanced care planning for end-of-life care should be discussed with all residents. And when I used to run the inpatient beds in my community hospitals, I used to have that discussion with every patient I admitted. And the reason being that for the frail elderly with multi-system pathology who have heart disease, possible cerebrovascular disease, possibly some memory problems, some kidney problems, if they have a cardiac arrest, the chances are that even the best will in the world, we're not going to have a successful outcome. So, and these patients would often say, if I have a cardiac arrest, I don't really want to be resuscitated. The important thing is, though, that we do not mix up, do not attempt active resuscitation order, a DNAR, with the fact that we would still treat people for pneumonia, a urinary tract infection, would admit people to hospital with appendicitis to have an operation to remove their appendix, because there's a difference between treating a treatable disease and trying to treat a non-treatable disease. And people often find it very difficult to have these discussions, but from my experience, the patients actually welcomed the discussion. The only problem I had occasionally was when the patients didn't want to be resuscitated if they had a cardiac arrest, but they were worried of the views of their families, and so you sometimes have to have those discussions as well so people understand why you're doing it. The reason why it's important for the patients and the staff is that the staff have an expectation of what's meaning for them, the relative, which therefore means we don't get the situation of ambulance staff flying to community homes to commence resuscitation on people where the chances of success are, to even say would be remarkably low, would be enthusiastic. even in the healthiest population, the survival to discharge from hospital after a cardiac arrest is probably below 10%. So we need to start to plan these things carefully, because that can have a big impact on the flow and the workings of the acute sector, as well as on the ambulance service. We also need to look at what we can do to care for people in their homes, because often within the care homes it's possible to do more things than you could in their own home. So it is possible to get specialists to view patients in a care home, and you can do some clinical interventions, particularly if there are some nursing home beds within that home. So an intravenous antibiotic visiting service that could call and administer intravenous antibiotics twice a day can keep people out of hospital. And similarly, subcutaneous fluids, small amount of subcutaneous fluids for people who are mildly dehydrated, can get them up and about very quickly without the deterioration and the loss of mobility and confidence that can occur by admitting someone into the acute sector. So we need to plan in advance with care home staff, and this also means the staff who are available 24 hours a day need to understand these advanced care plans and what the agreed response should be to unexpected events. And that can stop some of these unpredictable admissions to hospital which don't actually benefit the patients, but similarly cause a lot of problems in terms of, well, now we've got them here, what are we going to do, when they end up being investigated for things which again don't improve their quality of life or their life expectancy, because of course the hospital staff to some extent will do what they are trained to do regardless of the potential for the patients. Falls are a big problem, and I'm going to talk about falls in the general community later, but there is a problem in terms of care homes, because we do have some areas where the care homes try to have a no lifting policy, which means that when the patients fall, they call the ambulance service. The ambulance service turn up thinking they're coming because the patient's been injured. They then want to take the patient to hospital, and all these things could be managed better if the homes were understanding of what was the cause of the falls, what they can do to minimize those falls. But at the end of the day, we're not going to stop everyone falling. It's about risk management and not risk banishment. So fall services are being established in several areas as joint partnerships between the primary care services, the commissioning groups, the ambulance service and the community services. So the idea is to get an assessment in the home of someone who's fallen. As soon as they fall, falls are the biggest calls to the ambulance service. Probably at times between 15 and 19% of calls are the people who've had a fall. So for some of these, assessment in the home is appropriate, and what you need is a team who can safely exclude injury. And so in my area within the East Midlands, you would get a paramedic working usually with an occupational therapist or a physiotherapist, and they would go to the patient's home. The vehicles bring all the equipment to lift them off the floor, so a variety of entertaining inflatable devices that can lift them up off the floor safely without injuring the backs of the team sent to get them up into a chair or back onto the bed, and then do a proper assessment to check that they haven't injured themselves further. And then, of course, the important thing is, while they're there, do that assessment to try and find if there's anything further that can be done to prevent further falls. This can involve requesting medication reviews. It can be looking at the layout of the room, because patients frequently use their furniture to walk around rather than using aids. And basically, the other thing is, if the need for aids is identified, then these need to be rapidly available to the patients. The other thing is, what we want is a service that if there is a reason to admit them, they need to be able to admit them quickly into the right place, and not mean that the falls team comes out, which then sends you down to the emergency department, which then leads you to an assessment unit, which eventually ends you up into some frailty service several days down the line. If they need admission, we ideally need to get them in directly and quickly. But managing demand for all these things is a difficult bit. So, we try putting adverts on the sides of our vehicles to try and encourage people to use the right service, but we need services that are responsive and that the public understands if we want them to make choices that fit their needs better. So one of our services that is very underused is community pharmacy. Community pharmacists, highly trained, a lot of experience, and in many ways a lot more experience of the side effects of the drugs than the people who actually prescribe them. And what we need to use is to harness the skills of those pharmacists, which can then result in a decrease in the pressure on general practice, and then certainly an enhancement in patient safety. So pharmacists involved in practice reviewing ongoing repeat medications is good, but similarly these reviews can occur within the pharmacy, where pharmacists can actually do face-to-face reviews, because often the list of medications prescribed by the doctor may not correlate with what the patients actually take. So having someone who they know and trust, having that discussion with them, can lead to medication review and repeat medications being managed in a better way. So community pharmacists can also support hospital discharge. So when people are coming home and we know that they're going to require, for example, their medications to be packaged or delivered, the pharmacist can assist by advising on aligning the medications so the repeat medications are due at the same time, that they can be delivered and available for the patient when they need them. And a similar service is frequently offered within care homes, so that the patient's needs are reviewed and we don't keep filling people full of painkillers that they no longer need, or trying to give them tablets that they struggle to swallow, for example. The pharmacist is a really key member of that multidisciplinary community team and can often support the nursing staff as well when they're looking at patients in terms of long-term condition management and how we can maximise the benefits to the patients in terms of the medications that they need and how they use them. So pharmacists, particularly around the COPD and the asthma service, can also provide good ongoing education, and reminders from every clinician that they come across is one of the best way to reinforce these messages. Many community pharmacies around the country have been involved in minor ailment schemes, so these are sort of diverting some of the minor problems from general practice direct to the pharmacist, who can provide minor illness and ailment advice, and similarly they can give some advice on long-term conditions to again prevent people having attendances at the surgery that are unnecessary. People forget that pharmacists can provide urgent access to medications, not just the over-the-counter medications, but when people are on holiday or have lost medications, a pharmacist with appropriate evidence can often provide short-term supply to tide people over, again, not needing an acute attendance in surgery whilst they return home to where their medications are. And more recently, another service is to try and improve the flu vaccination rates, is that we try very hard to get people into the surgeries to get vaccinated. We also try and get the community nursing staff to pick up the patients that they visit at home. But if people are popping into the pharmacist to collect their medications, it's often a good time to get those at-risk groups vaccinated to prevent the spread of flu within the community. So, over to the final part of the talk, facilitated discharge. So, when people come to go home, we need to have the mechanisms in place so that the practice is aware and is part of that discharge planning for the frail and vulnerable patients. And in many ways, we need to look at this a different way, because often the hospital looks at it as an end of their care, and general practice probably looks at it as a continuation of their pre-admission care. And really what we need to try and do is to reframe it so that what we have is a discharge of those vulnerable patients by transferring their care to the general practice-led community team. And what that means is it becomes more seamless. The GPs are more involved in it, rather than getting a piece of paper that says, or an email that says, someone came home yesterday. We actually know in advance, so we can put in some anticipatory care, make certain the community team are involved, medications are understood by all, and again, set those expectations of what the service is going to be like from the start. Because what we're aiming to do is to get patients transferred out of acute hospitals as soon as there is no more benefit to be received from being in acute care. Because being in hospital, people lose their mobility, they lose their confidence, and what they need to be is back home, showing them how to get on with life, with the support available when necessary. And what we don't really want to be doing is keep people in beds to assess them to see how well they function in hospital, because to be honest, we don't really mind how well they function in hospital, because there's people to help you in hospital if you're not functioning. What we want to know is how will they manage at home. And the best way to work out whether someone will manage at home is to be able to discharge them and assess them in their own home. So having non-acute bedded alternatives for the few patients who cannot manage to go home to be assessed, but actually be aiming that the default position should be that people are going home, rather than the default position is, can we get this person home? If not, they're going to go into care. So get them from hospital back to their normal place of residence. And of course, their normal place of residence, if you live in a care home, was that care home. So we need to be getting them back to their home as soon as the acute problem has been treated. And the assessment of their functioning can be carried out in their normal place of residence. So before we decide, because someone isn't managing to walk around a hospital bed in an alien environment, that they need to be into a nursing or residential care home, surely we want to see how do they manage in their own home, where they are used to the environment. You probably find the furniture is positioned so they can usually walk around it safely, and they will often have developed a life that they are used to and safe in, and doesn't require an awful lot of preparation. So if we're going to do this, we need integrated health and social care teams that respond rapidly, so we can get that assessment and basic care within 2 hours of that person arriving home. So looking at getting them home with a care package initially that allows that assessment to be made to see what they need in the long term. And primary care is an essential part of making sure that they are welcomed back into their own home. So you've heard a lot of my ramblings from being a GP, a primary care manager, and a community hospital manager. And I think one of the problems is that in terms of the acute side, they feel that primary care is very much in control. And if we're going to be in control, we need to show people that we're in control and focused on the patients. We have to be aware of initiative-itis, because what we find is we get lots of services set up, but do we actually check to see that they provide what is needed? So if we're going to set something up, or we're going to look at what we do, we need to decide what we're trying to achieve. Look at it. Is it achieving the results? And the results may be that we have safer care. The results may be that we feel that the patient is getting a better quality of care. Or the result may be that the patients are very satisfied with this care. Those are all good reasons to do something. But if you don't know why we're doing it, why are we setting something up? So we need to be constantly aware that we're trying to improve patient flows, that we're trying to keep people at home, but we're trying to do it appropriately, safely, with good quality and good patient satisfaction. And you need to look at how we do our jobs on a day-to-day basis to achieve this. So that's enough ramblings for me, I think. So I'm over to anyone who has any questions. Very happy to take them by email, or that's my mobile number there. Happy to talk one-to-one if someone doesn't really feel that they want to open up the floor. So Paula, back to you.
Okay, thank you, John. That was great. Like John said, if you've got any questions, we've got 10 minutes. If anybody'd like to ask anything now, there's a couple of options. You can either raise your hand in the option panel on the right-hand side of the screen. Alternatively, you could write a question and then I'll read it out for John. So we'll give everyone a few minutes to do that. It looks like we might have a question already. Let's have a look. Nope, not just yet. So give it a few minutes for people. Okay, we've got a hand up from a lady called Karen Roach. I'll just unmute you, Karen. Hello, Karen, can you hear me? Hello, Karen? Right, I can't hear. Karen, is that you? Right, I can't hear Karen just at the moment. Oh, looks like somebody's typed a question in. This is actually from Deb Thompson, John. It says, do you have any examples of ambulance professional working in hospitals to improve patient flow? For example, I believe Heart of England has a paramedic in ED undertaking the RATS process.
Yes, there are several areas where ambulance staff are trying to improve that liaison between the pre-hospital and the hospital service. So it's very common to have emergency care practitioners, particularly, or people who've done sort of extra minor illness and ailment training to work within emergency departments. They do this for two reasons. Number one, because they're used to the way ambulance staff present and bring the patients, and so they're used to making rapid decisions. But secondly, what they also do it for is to try and educate the ambulance staff who bring the patient in. So when they bring a patient in to the RAT process, that's the rapid assessment and treatment part of the ED assessment, they try and say to the ambulance staff, well, actually, so you brought this patient here, but did you think of using an alternative pathway? Because this patient could have gone to an urgent care centre or to a walk-in centre, and you could have used your paramedic pathfinder tool to take them to an alternative pathway of care. So by putting ambulance staff into the emergency department, they can serve two purposes. Number one, they're generally pretty good at following protocols and doing things quickly and accurately. But number two, they're actually a good training resource to pass some of that knowledge back to their day-to-day colleagues to use in the future.
Okay, thank you, John. Looks like we've actually got Karen's question. She's typed it in now. The question is, of all the initiatives you have mentioned, do you think there are particular good starting points for the developments you have described?
That's not an easy one, Karen, because I've mentioned far too much. I think the thing that I think would be really useful to me is if we start at the front end, is number one, for a GP practice to look at how it manages those requests for assistance and decision making today, and trying to think of a few examples. So think of a child with a fever, a young adult with an exacerbation of their asthma, an elderly COPD patient who's got an exacerbation, and just try and think how that would be managed within your practice. And just think to yourself, how long would they wait for each step? And look at it and think, well, how could you make that easier, and how could you make that better? And if you look at those sort of simple things, you start to see how a practice could change the way they respond to those calls. And there's an element of, yes, if you make yourselves too accessible, the demand will increase to fill all those slots. We all worry about that. But similarly, if we get to the stage where the patients no longer need to push to get what they want, you'll find that they're happier to hang on because they know that actually when they have got a problem, they're going to be seen. So that's what that's where I would start with primary care. From an out-of-hours perspective, I would look long and hard at setting some standards. So if you're an out-of-hours provider, it's how long do you take to do that first assessment? How long is the standard then for that person to have a face-to-face assessment if they need one? And just to look and see, if you put yourself in the patient's shoes, if you ring up and you think you've got a chest infection, would you think on a Monday, if you rang the GP surgery, it was okay to be seen that morning, but actually if you ring the out of hours, it's going to be 6 to 8 hours? Try and just look at the standards and try and think, what do we think is acceptable for me, and try and use that to match across. From the discharge perspective, or from the other perspective, I think the pharmacist going into care homes is probably one that I think is really, really useful, and certainly regular GP visit in care homes and some care planning really, really useful. I think that's probably I'd say those would be my three areas of priority. I hope that answers your question.
Okay, thank you, John. Deb Thompson's got another question, which is, if people want one thing differently tomorrow, what would you suggest they do to improve patient flow?
If you want to do something differently tomorrow, I would look at how you manage the urgent patients in primary care to make it quick and easy to get that initial assessment, because that's the thing that'll make people more likely to end up having a primary care problem dealt with in primary care rather than looking for alternatives. That would be my choice.
Okay, thank you very much. It doesn't look like we've got any more questions from anybody listening in at the moment. Like John said, if you do think of anything, then use his, just send them to his email address or his mobile number. Yeah, all I need to say now is thank you everyone for listening in. Thank you, John, for that webinar. Just to remind everybody that the recording of this webinar will be available on the website shortly. Goodbye from all of us, and thank you very much.
And a happy Christmas to all of you.
And a happy Christmas. Goodbye. Thank you.